Suppose we got a patient with diabetes. We have to look at the fundus of the patient for changes in the retina. In case of mild NPDR, only few microaneurysms are seen. In case of severe NPDR, all the 4 quadrants will show the hemorrhages and at least 2 quadrants will show the venous bleeding, or at least 1 quadrant will show the irma. Anything which is falling between mild and severe is moderate NPDR. Moderate NPDR contains microaneurysms along with hard exudates and soft exudates. In case of proliferative diabetic retinopathy, there is new vessel formation in the disc or in the retina. After the PDR, there is vitreoretinopathy, diabetic vitreoretinopathy, followed by diabetic papillopathy. So based on the clinical picture, we have to investigate. We have to look at the blood pressure of the patient because hypertension, diabetes are the most common co-associated diseases. Followed by OCT macula to look out any macular edema, and FBS, PPBS, HbA1c, lipid profile, urea, creatinine, and treatment in case of CSME, intravitreal ranibizumab, focal laser for CSME. For PDR, laser photocoagulation. In case of vitreoretinopathy, treatment is vitrectomy. Here picture is showing macular edema. In case of hypertensive retinopathy, Salus sign is deflection of vein at the AV crossing, Bonnet sign is banking of the vein distal to the AV crossing, and Gunn sign is tapering of the vein on either side of the arteriolar crossing. So arteriolar reflex changes are silver wiring appearance due to opaque white reflex. This is copper wiring appearance due to thickened arteriolar wall. Followed by retinal hemorrhages and cotton wool spots, followed by disc involvement and disc edema. Investigations rule out causes of secondary hypertension, any renal disease, and diabetic and lipid profile, and OCT macula. Management for CME ranibizumab. If the diastolic blood pressure is more than 110 or chest pain or breathlessness is there, we have to refer the patient to emergency. Follow up every 2 to 3 months. In case of ARMD, gradual loss of central vision or asymptomatic, family history, obesity, hypertension, smoking, and hypercholesteremia are the risk factors. Dry ARMD, there is soft drusen throughout the macula. In case of wet ARMD, subretinal fluid and subretinal blood will be there. In case of late stages of wet ARMD, this blood and fluid will cause fibrotic changes at the macula. Investigations: OCT macula and fluorescein angiography if there is choroidal neovascularization. Treatment: antioxidants. In case of wet ARMD, intravitreal ranibizumab and photodynamic therapy.